Thanks for listening to the Wild Health Podcast. For the foreseeable future, you're not going to hear our normal intro or outro here. We're going to be releasing episodes very frequently as things are changing. This channel will be used for a very specific purpose. Number one, to communicate with our patients. We're somewhat overwhelmed, and the more we can communicate breaking news and recommendations from us to our patients all at once, the better. So if you're a patient, we're here for you if you need us, but if possible, please tune in here so we can both keep you up to date and conserve our time for the most critical tasks. Feel free to share this with friends and colleagues as well. Number two, we've organized as a group. We have infectious disease specialists, ER doctors, critical care doctors, and in total dozens of MDs, PhDs, and frontline clinicians who are going to be constantly evaluating the news and emerging evidence. We're then going to summarize and translate that for you here every day on the podcast. The speed of change with the circumstances will make us look foolish at times, but we're committed to pouring all of our resources and energy into doing what we can to help and make a difference. You can also follow our updates at wildhealth.com or our Instagram account at wildhealthmd. And if you're a patient, we're here for you. Please tune in here for the updates and let us know how we can help. Good morning, Tuesday, April 28th. Thanks for joining us for the Wild Health COVID-19 update. As of yesterday evening, Worldometer reported that we are now above 1 million cases in the United States and 3 million cases worldwide, with 210,000 deaths worldwide and 56,000 deaths in the United States. Data from the Financial Times shows that daily new coronavirus cases and deaths in the United States and the United Kingdom appear to be plateauing. Daily new cases in Turkey, which has been battling a quickly growing outbreak, also appear to be on the decline. Meanwhile, new cases in Singapore have risen sharply and continue to increase rapidly, while the outbreak in Japan appears to have slowed down. In U.S. news, daily coronavirus deaths in New York and New Jersey continue to decline. In his daily briefing this morning, Governor Cuomo reported 337 new coronavirus deaths in the past 24 hours, less than half of what was being reported at the peak of the outbreak in New York. Governor Cuomo explained that he would be working closely with Governor Murphy of New Jersey to coordinate reopening efforts, as the outbreak in the tri-state area has hit both states in tandem and with particular force. This week, the CDC added 6 possible symptoms of coronavirus infection to its list of possible indicators of coronavirus, illustrating the wide variation in patient presentations. The list previously included only 3 symptoms. Those were fever, dry cough, and shortness of breath. The expanded list of symptoms now includes chills, repeated shaking with chills, muscle pain, headache, sore throat, and a loss of taste or smell. We've also seen some other symptoms. Some people may have heard of COVID toes. We've seen people with fingers and toes that have some rashes. Basically, there are a wide range. These symptoms are presumably based off of repeated anecdotal reports from physicians caring for patients diagnosed with COVID-19 that are being reported to the CDC. And it's unfortunate we're in a situation where we're still having to ration and decide who to test and who not to. Hopefully that situation will get better and we'll be able to simply test more widely. But for now, these are some of the main symptoms that you would probably be seeing with an infection.
Yeah, I appreciate the CDC releasing that. I feel like we've been talking about some of those symptoms for quite a while now. So it's good to see that the CDC is catching up on some of that data.
Well, there were other symptoms that weren't on the list too, which we've talked about with like GI symptoms. That wasn't on there, but
Yep.
We've seen a fair amount of patients in the U.S. at least present with that as well.
Yeah, and it's interesting because we've actually seen data on that as well. And yet, for whatever reason, we're still not seeing, that specifically mentioned by the CDC. So I've got a couple articles I wanted to talk about today, Matt. Well, the first one isn't actually an article. It's going to be articles, but the data is so fresh that we don't really have any literature on it yet. So you may have seen an article in the Washington Post or really any other news outlet over the last few days that's been talking about this new pattern of strokes in young, healthy patients with COVID. And the data, or at least the reports from the physicians on the front lines, is pretty chilling. So this is mostly coming out of New York and Philadelphia. There's apparently 3 separate groups that are about to publish data on this, although none of them have been published. Later this week, we should get a report published in the New England Journal of Medicine coming from Mount Sinai, talking about COVID patients with large vessel strokes. This is reportedly going to be a story of 5 patients, ages 33, 37, 39, 44, and 49 years old, all of which who had large vessel occlusion strokes. So this means not a minor stroke. This means basically half of your body can't work, you can't speak, really, severe, horrible strokes. Of those patients that were all relatively young, 1 died, 2 of them are still in the hospital, 1 has been released into rehab, and at this time, only 1 of those 5 people can actually talk. So this is horrible. This is capturing headlines. These are obviously small numbers, but they are terrible, terrible things. And what's interesting is that it's happening in young patients. And, I don't know about you, Matt, but I've spent a lot of time in the emergency department, and it's not very common that you see a stroke this large, in an otherwise healthy, young 30-year-old person. So obviously concerning.
No, you remember those. That's how rare they are. You remember it when there's a patient in their 30s or early 40s that has a stroke.
Yep. So at Mount Sinai, they've actually gone on to report to the news outlets that they've seen basically a doubling in the number of stroke patients over the last few weeks during the COVID outbreak. And about half of those patients who have had strokes have been COVID positive. Of those, they're saying that the patients are typically about 15 years younger than they typically expect for their average stroke patient. What's interesting is a lot of these patients are doing relatively well with their COVID symptoms. Some of them were fairly asymptomatic. Some of them had mild respiratory symptoms. And then next thing you know, they've got a large stroke. And it's interesting, we've known about this increase in clotting for some time with regards to COVID. There was an article published in April 10th in Thrombosis Research. This was looking at 184 Dutch ICU patients. Name of the article was Incidence of Thrombotic Complications in Critically Ill ICU Patients with COVID-19. They saw an overall prevalence of blood clots of 31%. And most of those blood clots were in the lungs, but about 4% were thrombotic events that were actually strokes, meaning they were occluding arteries. And that could happen in the brain, that could happen in the heart. And this is much higher than what we typically see in the general population of ICU patients. So typically you might see maybe 5%, maybe 10% of blood clots in this patient population, not 31%. So there's something here. The problem is we don't know what's causing it. I've got a few ideas. So one, we know that inflammation can increase blood clots, and certainly there is a phenomenal amount of inflammation going on with COVID-19. But what's unusual with that is you would expect to see more blood clots in the sicker patients, and it sounds like, at least based on these reports, we're seeing a moderate number of blood clots in fairly non-sick patients. Other thoughts that I had are we potentially sedating these patients more than other ICU patients? And that thought came to me because I was talking with an ICU friend in New Jersey who was talking about how they've basically just been putting people out for 2 weeks on the vent. Like once they're on the ventilator with COVID-19, in order to really give their lungs a break and prevent any self-imposed lung injury, they're basically heavily sedating the patients. And you and I both know, Matt, that with increased sedation means less movement of your extremities. Less movement of your extremities can lead to increased blood clots. So that could certainly lead to an increase in blood clots. And then the other thought I had was, are these patients getting less care? So in the realm of PPE, it's harder to go in and out of patients' rooms. The nurses, the physicians have to put on more equipment to go in and out of rooms. So I think it's certainly possible that we could be seeing less movement of our ICU patients. And then the last thought I had was actually coming out of an article in 2004 from the Journal of Pathology. And this was with regards to the SARS-1 outbreak. They were looking at tissue distribution of the ACE2 enzyme. And what they found, which is really interesting, is that you actually have ACE2 enzyme not just in the lungs and in the gut, like we've talked about so many times before on the podcast, but it turns out it's actually on the walls of the insides of your vessels. So inside the arteries, inside the veins, there's actually this ACE2 enzyme, so you can actually get attachment and basically assault of these cells by the by the SARS-CoV-2 virus, and that could be causing localized inflammation and irritation of the lining of the cells. So this discussion is mostly conjecture. We obviously need better data, but it is really interesting, and it looks like blood clots are going to be here to stay for a while with regard to the CoV-2. Hopefully we can get down to the pathophysiology and start to come up with a plan as to how we can treat this and decrease the likelihood of these events.
Mike, I didn't get to really dig into this literature, but you talked about the percentage in the ICU that have clots. Did you see anything about those just hospitalized on the floor?
No, I haven't seen anything. Yeah.
Okay. Yeah, I'm just wondering about what we do about this and what we translate, like who is on a heparin drip and who's getting anticoagulated versus not. Like ICU, that makes sense. What about the floor? What about patients who are just sick and at home? That seems like probably a stretch, but I guess I haven't really seen data on people at home coming in with clots who have this, and I haven't seen it on the floors either. So I guess we'll just keep watching for that.
We're waiting for the data. We're waiting for the data on the people in the community who are having these thrombotic events, like stroke, for example. So that is hopefully coming soon. We've got 3 reports that should be published, at least in preprint, relatively soon regarding that. The numbers are going to be so low, Matt, that I don't think you're going to see any recommendations that people start blood thinners, at least based on my understanding of the data thus far. I think it would be the likelihood of having a negative effect from the blood thinners seems like it'll probably be higher than the possible positive. But that, I could be wrong. That's just my guess at this point. Another article I wanted to talk about is one that I'm surprised we haven't talked about yet. This is coming from actually one of our guests on the podcast, Chris Mason, who, if you have not listened to his initial podcast with us during our Wild Health Summit or the follow-up podcast we did with him, you should go back and listen to those because the man is quite smart. He recently published an article on April 21st, which we talked a little bit about on the last podcast with him.
Technically, it's preprint, right? Not actually published yet.
Correct. Yeah. Sorry. Published on BioRxiv as a preprint article. So as far as I'm aware, has not necessarily been accepted yet, but I know he has submitted. The name of the article is Host Viral and Environmental Transcriptome Profiles of SARS-CoV-2. And this is an extremely long article that is just full of awesome information. It's really probably 3 or 4 articles that Chris just merged as one. If you really break it down, there's so much in there. The first thing that he talks about is something called a LAMP test, or a loop-mediated isothermal amplification. This is something that we've talked about in the past on the podcast, but Chris they developed a LAMP test, and he found an overall sensitivity for COVID-19, for diagnosing COVID-19 of 95.6% and a specificity of 99.4%. And that was pretty well correlated with the number of viral copies in the sample. So 80% sensitivity at 50 viral copies, 90% at 100 viral copies, and 100% at 500 viral copies. He found a sensitivity really approaching 100% at a high viral load. This is extremely important. And Matt, maybe you'd be the best person to explain to everybody why this is so important.
Yeah, and we normally talk about tests in terms of sensitivity and specificity, but really with these viral tests, we also need to talk about the LOD, the limit of detection, like how few viral particles can you actually detect. So that's why he kind of broke it down into, okay, how much virus is here and how good are we at detecting it. So if you get a good sample, this is a really, really good test, basically, as a summary. The reason why we've been excited about this test are for a couple reasons. Number one, it is a test that is simple enough to not have to require a full lab. So we are running the CDC PCR test in our lab, running other tests in our lab, but this one could be deployed in the field. And it also, the other reason why we're so excited about it is because you can do a large number at a time asynchronously, meaning instead of one test at a time that you're getting results every 15 minutes with the Abbott test or every 30 to 45 minutes with the Cepheid test, which with the Cepheid you can do 4 at a time. You can do more than that at a time. But anyway, instead of being synchronous, having to wait for one test to be done or a certain number of tests to be done, then adding another, you have a warm pull that you are putting these tubes into, and you get a color change, and you can put as many in at a time as you can fit, and you can continue to add them in and then take them out when the time is up. So it allows you to do a much larger number. And people are talking about doing tens of thousands in a day in a lab, and being able to roll these labs out into multiple places. So when we keep talking about testing being a problem in this country, we believe that this is really going to be a big part of the solution. So we're continuing to talk about it because we're just not hearing it talked about in other places. But Dr. Mason's doing incredible work with this. Dr. Bright in our lab is also doing this test as well, and they're collaborating on how to do this most efficiently. But we think this is going to be a real game changer because of the asynchronous nature, how you can do this not necessarily in a high-tech lab, and you can do a large number in a short period of time.
So that sounds like a paper in of itself, yet Chris's paper continues to go on and talk about other things as well. He went over a fairly in-depth analysis or genomic analysis of the virus that they found in New York City, mostly from the subways. And they found that the majority of the virus came from Western Europe, which is interesting. They also went over some of the variants of the virus that they've seen in the New York City samples, which is also interesting. I don't think much to translate there. And then they go into something that just kind of hit me by surprise. I didn't even realize Chris was really looking at this. They start talking about ACE2 levels in the host, basically. And they found higher ACE2 enzyme levels in patients with a high viral load, which is interesting in of itself. But then they went on to look at patients with a history of ACE inhibitor exposure. And they found that the people who were on ACE inhibitors who got the virus were, first off, more likely to actually get the virus. And then also were more likely to require intubation and a ventilator by a hazard ratio of 2.6, and less likely to survive with a hazard ratio of 1.6, which is kind of crazy. This is something that we have talked about on the podcast before. Do ACE inhibitors, do angiotensin receptor blockers, do these high blood pressure medications lead to an increase in severity of the illness, or even an increased likelihood of getting the illness? And this preliminary data from Chris obviously suggests so, which is kind of scary. I recently sent this paper to a friend of mine who is also a physician who was on blood pressure medication, and he's stopped taking the ACE inhibitor at this point based on this data. So, this data needs to be sussed out. I'm not saying that people need to make modifications to their medication that they're currently on. They need to talk to their physicians, but in my mind, this is certainly concerning and potentially pointing to an increased risk associated with taking ACE inhibitors, at least for COVID-19.
Mike, the first place a lot of people's mind goes is to confounders here. We've talked about hypertension being a risk factor, making you at higher risk for bad complication, and people with hypertension are on hypertension medications like ACE inhibitors. So could this be just because people are hypertensive and not the ACE inhibitor itself?
It's possible, Matt. So yeah, clearly that is a possible confounder. It looks like Chris probably corrected for that in their analysis, because they talk about adjusting for predetermined risk factors for disease. And I think hypertension has been a fairly well-established risk factor, along with age and obesity, lung disease. So while it doesn't specifically say to the T that they corrected for hypertension as a risk factor, it does suggest that they corrected for other risk factors. So I can't say that for sure, but I think they probably did. I'd like to get Chris back on to talk a little bit more about this, to try to suss this out, because this could be extremely important data if that is the case.
Yeah, I mean, that was my first thought when I saw this. And then they did have the statement in there that they tried to adjust for confounding factors and other risk factors. But I mean, it didn't really go into great detail about how. And they're good scientists, so I'm sure they did. But we also know that even when you do that, you can never truly fully adjust. And that's why we need randomized controlled trials. And this was a 44-page paper. So to go into further detail about all those details and questions that it brings up would probably not have been completely possible. So hopefully they'll kind of suss that out a little bit more and talk about it some more. But it was probably the most excited I've been to read a 44-page paper in a long time. It was a really interesting paper that I can't wait for more data to come out of their lab and for us to continue
I can't tell you how often I make it through an entire 44-page paper, Matt. So saying that is saying something. If this is if you are a scientist, you should go read this paper because there's just so much there. It really is. It's worth it for sure.
It was like a page turner. Like every page, I'm like, are they going to find viral particles in the subway? And does ACE inhibitor increase? Going to have a high hazard ratio? It was like every page, I'm coming to some new conclusion. What is the true sensitivity of this lamp test?
That's exactly what it was like. Yeah.
All right. So we're done nerding out for the day. We were approached recently by, we have a couple of our patients who we work with, clients we work with a group that does some really great business coaching. And they have been seeing the stories in the news, as we have, about medical offices and clinics really hurting right now and having a tough time. A lot of primary care clinics closing. And so they reached out just to say, hey, could we help in some way? And they offered to do a free webinar for physicians, medical clinics. A lot of times physicians, primary care offices aren't necessarily the best business people. They're great clinicians and great providers. But during this really unprecedented time, a lot of them are suffering financially. So we're having a webinar, our next webinar. It's a completely free webinar. You can sign up at wildhealth.com. It's for physicians and clinics. If you want help kind of navigating this really tough business time, it's a great group of business coaches who are willing to help for free and do this webinar. So this will not be led by us. We'll be there and we'll participate, but this is really a guest kind of webinar just because we do see a lot of physicians and clinics out there hurting. So if that's you and you just want to listen in, just get some free advice from a group that does a great job, go to wildhealth.com and register for that webinar this Friday, May 1st. And we'll be back tomorrow with another podcast.
Thanks so much for listening to this COVID-19 update. Please send us your questions or follow along on Instagram and Facebook at WildHealthMD. And just to be clear, this is not medical advice. No patient-physician relationship has been established, and this resource is really for general informational purposes only. And finally, if you want to spread the word, please send this podcast to friends and family and give us a review on iTunes. Thanks again, and stay safe.